Good morning, everyone. Today I'm going to introduce you to a fascinating and increasingly important procedure in urology, transurethral seminal vesiculoscopy, or TUSV. This is a minimally invasive endoscopic technique that has revolutionized how we manage persistent hemospermia, ejaculatory duct obstruction, and other seminal tract disorders. Over the next 10 minutes, I'll walk you through the anatomical foundations, surgical techniques, clinical outcomes, and future directions of this procedure. By the end, you'll understand why seminal vesiculoscopy represents a significant advance in men's healthcare, offering superior outcomes with minimal complications compared to traditional approaches. So, when is transurethral seminal vesiculoscopy, or TUSV, truly indicated in clinical practice? The primary application for TUSV is for cases of persistent, painful, or recurrent hemospermia. This is particularly relevant when the condition has not responded to at least 3 months of conservative medical treatment. TUSV is also the preferred procedure for diagnosing and treating ejaculatory duct obstruction. We diagnose this obstruction based on specific criteria, including a low ejaculate volume, typically less than 1.5 milliliters. Further diagnostic indicators include an acidic pH level and low or even absent fructose in the seminal fluid analysis. Transrectal ultrasound, or TRUS, plays a crucial role in confirming these diagnoses. TRUS imaging will typically reveal a seminal vesicle diameter greater than 1.5 centimeters. It can also identify midline cystic lesions, which are key indicators of obstruction. Finally, TUSV is also effectively utilized to manage and diagnose various other seminal vesicle pathologies. These include seminal vesicle stones, cysts, and even tumors, offering a comprehensive approach to treatment. Ultimately, TUSV provides both a diagnostic view and a therapeutic intervention in a single, efficient procedure, making it invaluable in urological care. Understanding the anatomy is absolutely critical for successful vesiculoscopy, a procedure that demands precise knowledge of the male reproductive system. The verumontanum is our key landmark. It's a small elevation in the prostatic urethra that houses the openings to the prostatic utricle and the bilateral ejaculatory ducts. These ejaculatory ducts are approximately 2 centimeters long, and their orifices are typically covered by a thin, membraniform substance. Here's the crucial pathophysiology. Chronic inflammation thickens this membraniform tissue, progressively causing stricture, which is a narrowing of the ducts. This stricture impairs drainage, leading to stasis, which promotes infection and inflammation, creating a vicious cycle that exacerbates the problem. The prostatic utricle is a midline structure at the verumontanum that serves as an alternative access point when the ejaculatory ducts aren't directly visible during the procedure. The ejaculatory ducts typically open at the 5 and 7 o'clock positions relative to the utricle, providing a consistent anatomical reference for surgeons. Finally, the seminal vesicles have a complex honeycomb architecture with multiple interconnected cavities, making them challenging to navigate. This intricate structure requires systematic exploration during the procedure, and it's important to remember that individual anatomical variations are common, demanding adaptability from the surgeon. Dr. Chen and colleagues have elegantly categorized 4 distinct surgical approaches based on how we access the seminal vesicles during TUSV procedures. Type A, seen in about 17% of cases, involves direct visualization and entry into the natural ejaculatory duct opening. This approach is ideal when the duct orifice is clearly visible and easily accessible to the surgeon. Type B, the most common at 51%, is transduct fenestration, a crucial technique. Here, we carefully scratch through the tissue at the 5 and 7 o'clock positions to create access to the ejaculatory ducts. This technique works well when the natural orifices are not immediately apparent or are obscured. Type C, occurring in 29% of cases, is transutrical fenestration, offering an alternative pathway. When we cannot locate the ejaculatory duct, we puncture through the utricle wall directly into the seminal vesicle. This alternative pathway is particularly useful in patients with difficult or atypical anatomies. Finally, Type D represents cases where we cannot achieve access. Fortunately, this occurs in only 3.5% of procedures. Understanding these 4 distinct approaches allows us to adapt our technique to individual patient anatomy, optimizing outcomes. Now let's discuss the actual surgical technique. We use an ultra-thin rigid or semi-rigid ureteroscope, typically 4.5 to 6.5 French in diameter. The procedure begins with identifying the verumontanum landmark, then selecting the appropriate access approach based on what we see. We then systematically explore the seminal vesicle cavities, being meticulous in our examination. Here's the most critical principle, and I cannot emphasize this enough. We must maintain low-pressure irrigation throughout the entire procedure. High-pressure irrigation risks extravasation and tissue injury. Hand-controlled pressure changes actually help us reveal hidden structures. This video from Dr. Chui Ka-Lun demonstrates the actual surgical technique. Notice how carefully he navigates the anatomy and maintains gentle, controlled irrigation pressure. This is the gold standard of practice. After visualization and treatment, we irrigate any hemorrhagic material, fragment calculi using holmium laser lithotripsy if present, and perform antibiotic lavage with 400 milligrams of moxifloxacin in saline. Post-operatively, we place a Foley catheter for 24 hours and administer intravenous antibiotics for 48 hours.
Understanding the pathophysiology of hemispermia is crucial for effective treatment, explaining precisely why vesiculoscopy works so well. Liu and colleagues' landmark 2009 study demonstrated that obstruction or stricture at the verumontanum is present in nearly all hemispermia cases. This obstruction is often caused by chronic inflammation, which progressively thickens the membraniform wall, leading to a worsening stricture over time. This process creates a 5-stage, self-perpetuating cycle that exacerbates the condition. First, stricture impairs normal drainage of seminal fluid. Second, this stasis promotes infection and further inflammation within the ducts. Third, the ongoing inflammation further worsens the stricture. Fourth, chronic stasis eventually leads to the formation of calculi. And fifth, these calculi create additional obstruction and serve as a persistent nidus for infection, completing the vicious cycle. This vicious cycle clearly explains why antibiotics alone often fail to resolve hemispermia. The mechanical obstruction must be directly addressed. Vesiculoscopy effectively breaks this cycle through multiple simultaneous mechanisms. We dilate and incise strictures to restore proper drainage, remove calculi and any infection nidus, and clear hemorrhagic and purulent material. Finally, we perform antibiotic lavage to treat any residual infection, ensuring a comprehensive approach to healing. This multi-pronged approach achieves remarkable 94 to 97% cure rates for persistent hemispermia, which is far superior to conservative management alone.
Transurethral seminal vesiculoscopy, or TUSV, demonstrates truly impressive clinical outcomes for patients. A 2009 study by Liu highlighted a 93.1% definitive diagnosis rate and a 94.4% symptom cure or improvement rate. Further reinforcing these findings, Chen's 2021 multi-center series, involving 144 patients, achieved an outstanding 96.53% technical success rate. These consistently high percentages across different studies underscore the remarkable efficacy and reliability of TUSV. Regarding complications, the safety profile of TUSV is equally outstanding, demonstrating minimal adverse effects. Sexual function changes occur in only 10.81% of cases, and these are mostly minor and reversible, ensuring patient quality of life. Post-operative epididymitis is a rare occurrence, reported in only 0.7% of cases, reflecting careful procedural technique. Retrograde ejaculation is essentially 0%, and critically, rectal injury or fistula has not been reported in the literature. In contrast, turd or transurethral resection of the ejaculatory ducts often presents with higher complication rates and less favorable long-term outcomes. Seminal vesiculoscopy thus offers superior safety with comparable efficacy, alongside substantially better preservation of normal anatomy and sexual function. Dr. Chui Ka-lun, an honorary associate professor and fellow of the Royal College of Surgeons of Edinburgh, has made significant contributions to advancing the field of seminal vesiculoscopy. His elegant conceptual framework describes Path 1, the natural orifice approach, as analogous to ureteroscopy, simplifying understanding for urologists. Path 2, involving fenestrating through the utricle, is compared to functional endoscopic sinus surgery in otolaryngology, drawing another familiar parallel. This bridge helps urologists understand vesiculoscopy through familiar endoscopic procedures, significantly accelerating their learning curve. Dr. Chui's extensive clinical experience, comprehensive documentation, and educational materials, including surgical videos disseminated internationally, have been invaluable. He emphasizes proper patient selection and psychological support, recognizing that these patients often suffer significant anxiety about their condition. His clinical practice reflects evidence-based application of landmark studies while adapting principles to individual patient anatomy. Dr. Chui's global impact has significantly advanced seminal vesiculoscopy adoption and safe practice worldwide, benefiting countless patients. Looking forward, several exciting developments are on the horizon for transurethral seminal vesiculoscopy, or TUSV. Technologically, we anticipate continued miniaturization of endoscopes and significantly improved optics, enabling less invasive procedures and access to smaller anatomical structures. Advanced imaging techniques like narrowband imaging and confocal endomicroscopy will be integrated, enhancing the detection and characterization of subtle mucosal abnormalities. Furthermore, robotic-assisted vesiculoscopy is on the horizon, promising improved precision, dexterity, and control for surgeons during TUSV procedures. Diagnostically, we expect refinement of the endoscopic seminal vesicle milking test and the discovery of new biomarkers to predict treatment response. Artificial intelligence for image analysis will also enhance our ability to select and manage patients by detecting subtle abnormalities and predicting outcomes. Clinically, long-term fertility and offspring health studies are crucial, alongside expanded indications for TUSV beyond ejaculatory duct obstruction. Finally, structured training programs, international registries, and fellowship training will standardize and globally spread this advanced endoscopic technique. Let me summarize 6 key takeaways for clinical practice. First, patient selection is critical. We need persistent symptoms lasting more than 3 months with failed conservative management of at least 4 weeks of antibiotics. Second, anatomical knowledge is essential. You must understand the verumontanum, the 4 surgical approaches, and how to identify the membraniform wall. Third, low-pressure irrigation is a critical safety principle that prevents extravasation and tissue injury. Fourth, we must address the vicious cycle simultaneously, targeting stricture, infection, and calculi all at once. Fifth, the safety profile is excellent with serious adverse events occurring in less than 1% of cases. And sixth, seminal vesiculoscopy offers superior outcomes compared to TURED with fewer complications for ejaculatory duct obstruction. The bottom line, when properly indicated and technically executed with meticulous attention to anatomical landmarks and low-pressure technique, seminal vesiculoscopy offers excellent outcomes with minimal morbidity.